30th of January. Okay, thank you. Great. And so my name is Lauren Close, and I want to welcome you all today to the Winter 2024 COVID Information Commons Research Webinar. My name is Lauren Close, and I'm the Operations and Communications Manager for the Northeast Big Data Innovation Hub here at Columbia University. Let me share some exciting slides with you all. I'd like to introduce you all this afternoon to the COVID Info Commons, or the KIC. We are a COVID-19 research collaboration platform, which is brought to you by the Big Data Innovation Hubs and is funded by the National Science Foundation's Convergence Accelerator. The KIC brings together scholars from all over the country and around the world to share their research findings in the form of lightning talks. And today, each of our speakers will be sharing with you their research as relates to COVID-19. I should note that we at the KIC are committed to providing a supportive and welcoming environment to everybody who works, studies, and interacts with the COVID-19 and NEBD Hub community at public events. So we definitely encourage you to review our code of conduct for online programs. This code of conduct includes information about reporting conduct or accessibility features for our events, and I've just dropped a link to those resources in the chat. But before I hand you over to today's fantastic group of speakers, I'd like to first introduce the Hub's Executive Director, Florence Hudson, who will give us some background info on the KIC itself.
Thank you, Lauren. You always impress me with your multitasking capabilities, YouTube Live and show the slides and the code of conduct. So thank you. Lauren is our famous operations and communications manager at the Hub, and she helps with all our programs. So thank you for the introduction. My name is Florence Hudson, and welcome to the January, barely still January, 2024 KIC webinar. In these webinars, we like to help our researchers that are funded by NSF, NIH. We actually have one funded by the VA today. We've had CDC before, to share the research they've done in this longitudinal COVID world, and enable researcher collaborations for today and into the future. So NSF originally contacted the Northeast Big Data Hub that we lead at Columbia University and asked us, with the other 3 big data innovation hubs around the country in the South and the West and the Midwest, to create a COVID Information Commons, a portal for people to be able to easily find initially NSF-funded research related to the COVID pandemic, the COVID-19 pandemic. So we were very fortunate to be able to lead this from Columbia. That was our 2020 award. And we stood up this initial portal so that the KIC could serve as an open resource to explore research addressing the COVID-19 pandemic. We had a COVID Research Explorer machine learning maps tool that you'll see more about, and initially a simple search mechanism into NSF for COVID, and then we kind of kept growing. So Lauren, maybe if we can go to the next slide. NSF came to us and said, well, if we gave you additional funding, could you keep doing this? Presciently, 4 more years of it. So it goes through 2025 at this point. And so the KIC Extension Award came out at the end of 2021, and that enabled us to do something that we felt was very important. One was to continue this work, continue the researcher collaboration, but importantly, since this is a disease, we really wanted to include NIH, NIH researchers and awards. And so we started out with, there were 32 NSF-funded COVID awards when they contacted us in March of 2020. There were 732 approximately at the end of 2020. Then we added NIH, and we continued to use the APIs to download the awards every month. Now we have over 10,200 NSF and NIH COVID-related awards. And so the KIC is a portal to enable collaboration, research discovery. We've had global research created where there was a researcher in South Korea that looked at some of these lightning talks and research, collaborated with one of the research colleagues in the UK, and there's a global collaboration going on. So we really encourage everybody to leverage this resource. So with the Kick Extension Award, we were able to bring all these awards to bear, as we said, and you can easily browse the database. There's a COVID Info Commons, regular. Oh gosh, we have over 12,000 now. Oh, I'm not paying attention. So you can go in and put the name of a researcher. You could put the name of the research. On the right here, you can see, or in the middle, filtering results. You can put the funder. You can choose NSF or NIH at this point. You could choose the directorate or the institute or center, the organization who got the award, the state or territory they're in. Most things are in the US. NIH has a little bit in Canada and some other places. PI name, different facets here to allow you to search. And so it's a very rich search. And there's another tool that we have called the COVID Information Commons Research Explorer Machine Learning Maps tool. And what this allows you to do is go against all these different awards and get kind of a thematic view of what are the most popular terms. So it lets you see what is and isn't there. So like for somebody in NSF or NIH, they could say, what haven't we funded? What is not included yet? If you look on the next page, I think we have another view of this faceted search. This is my favorite one, the kaleidoscope view. But what you can do is put in a query like you want to look at all the awards that mention epidemiology. You can see it's a much smaller scope. And then it actually clusters them with this machine learning clustering tool. So you can find other institutions and other researchers that are working in areas similar to yours or similar to your interest area. There's an easy toggle, actually. I think this view has the institution like Emory University in the top middle. If you were to click on the little Mickey Mouse ears, as I say, the gears near the top right, you can actually just flip that to PI. So you'd be able to say, oh, who is it at Emory? Oh, gosh, I was a postdoc with them. So it actually allows you to find the research and the humans, which we think is very powerful. So those are some of the tools that we have.
Thank you, Florence. Speaking of humans, and this is one last announcement that I want to get to before we talk about today's presentations. We actually have two working groups for the COVID Information Commons, and one is a student working group, which is spearheaded by our work study students. And the student working group has over 360 members from all around the world. It's a really wonderful international collaboration space for STEM students interested in working together on data science projects related to COVID-19. So this last semester, we launched a data visualization challenge, which encouraged students to learn about data science and data visualization. The students learned about these topics over a 9-week period that included 2 office hour sessions to support their learning. And students can now participate in this challenge asynchronously via a link that's on our group webpage. I'll include a link to that in a moment. And beginning this spring semester, as you can see, our next meeting is on Friday at 11 a.m. Eastern. We're going to be launching a new project which focuses on the effectiveness of different pandemic policies around the world. So we're really excited about this one. We think it's a great opportunity for students, and I'm going to share some details with you in the chat right now. So we hope you'll have our students join. The other thing that may be more applicable to the group that's here today is a researcher working group at the KIC, which has over 150 members from 93 different organizations around the world, so also very diverse and very collaborative. Our next session for this group is on Valentine's Day. So remember us when you're writing your Valentines. We're going to be meeting at 2 p.m. on Wednesday. To receive a calendar invite for that meeting, you can also email me directly, and I'll drop those links in the chat as well. Like I said, we have a lot going on. And then without further ado, I will hand it over to the speakers of today's webinar series. This afternoon, we'll be hearing from 6 fantastic researchers who are at the NIH, NSF, and the VA. If you have any questions for our speakers during their presentations, either feel free to drop them directly into the chat or hang on to those questions for our Q&A session at the conclusion of all the presentations. But I will stop talking, and I'll definitely hand it over to Courtney Baird from Brown University, who is this afternoon's first speaker. Courtney, the floor is yours.
Thank you, Lauren. All right, I'm just going to take a minute to get set up here. All right, Lauren, can you see my slides okay?
I can, they look great.
Great. So hi, everyone. My name is Courtney Baird. I'm a 5th-year doctoral candidate in the Health Services Research PhD program at Brown. My main area of interest and expertise is in evaluating the effectiveness of public health policies. So naturally, during the pandemic, I developed an interest in figuring out whether any of the COVID-19 mitigation policies were effective, and if so, which ones were most effective, and that's what I'll be talking about today. So before I get started, I'd just like to quickly acknowledge all of my co-authors and also thank the NIA for funding this important work. And the work that I'm presenting today is actually in Press at Health Affairs and will be published sometime in February or March. So first, I'd like to start off by providing some context on what really motivated this study. So given the initial lack of vaccines and therapies to address COVID-19, counties adopted several non-pharmaceutical interventions, also known as NPIs, to slow down COVID-19 transmission and prevent healthcare systems from reaching full capacity. So early evidence has been mixed about whether these NPIs have been effective. Some studies have found a significant association between NPIs and slower COVID-19 growth rates, while other studies have also found that NPIs had no effect on COVID-19 transmission. So these mixed findings may be due to several factors, but mainly most of these studies were conducted at the state level and did not account for county level differences in the adoption and repeal of NPIs, infection burden, testing levels, and population sociodemographic characteristics. Additionally, most of these policies only covered the first 1 or 2 waves of the pandemic, and only studied one NPI and didn't include all of them. So to address these shortcomings, we used daily county level data to evaluate the joint effect of 5 different NPIs on the speed of COVID-19 transmission over the course of the first 4 waves of the pandemic. We also described policy implementation and county level characteristics associated with policy implementation during the pandemic. So now I'll move on to talk about the data and methods that we used. So we used CDC datasets to obtain daily county level data for all 5 policies and for COVID-19 testing and vaccination rates. And we obtained daily county level COVID-19 cases from the USA Facts COVID-19 dashboard. So we obtained data on numerous county level characteristics, such as the distribution of age, sex, race, and educational attainment from the US Census Bureau and the Department of Commerce. And we also obtained county level 2020 presidential election results from the results published by Fox News, Politico, and the New York Times. So we evaluated the potential of the policies to reduce the COVID-19 transmission rate separately for each of the 4 national COVID-19 waves for which policy data was available, and which are shown on this graph. And we also conducted the analysis with all of the waves combined. So ultimately, we decided to exclude wave 5 from the analysis because the CDC policy datasets ended on August 15th. So we were not able to evaluate the entire upward slope of wave 5. So we evaluated the impact of 5 different policies on the growth of COVID-19, including large gathering bans, stay-at-home orders, face mask mandates, and bar and restaurant closures. So now I'll just review the steps that we took to model the policy exposure. So first, for each policy, we calculated a 5-day lagged 7-day rolling average of cumulative policy days, because people who test positive on a given day were, on average, exposed to the virus 5 days earlier, and that's based on prior research. So second, we created a composite NPI variable calculated as the sum of cumulative policy days for all 4 policies. So we decided to use a composite policy variable because counties implemented and repealed most of the NPI policies at the same time, which leads to a high degree of multicollinearity among policies, and that makes it really difficult to identify individual policy effects when you're including them all in the model at the same time. So in our regression models, we evaluated 2 different versions of this composite policy variable, a continuous version and also a binary version that compares high policy counties versus low policy counties. So we evaluated the impact of this composite variable on 7 outcomes, which are defined as the number of days counting from the county's at-risk start date that it took for the county's COVID-19 7-day rolling average case rate to reach or surpass 50, 100, 200, 400, 600, 800, or 1,000 infections per 100,000 people. So the at-risk start date for each county in each wave began on the first day in which the county exceeded 10 new COVID-19 cases per 100,000 people, And the follow-up period ended either when the county reached the specified threshold or on the day in which the wave peaked in that county. So for our statistical approach, we performed multivariable Cox proportional hazards regression models. We excluded counties that never reached 10 cases per 100,000 during a wave because we didn't consider them to be at risk. And then also counties in the bottom 5% of county population size, because small populations can lead to overinflated case rates that would result in imprecise estimates. So aside from the previously mentioned county level demographic characteristics, we also controlled for several other COVID-19 related confounders, including the county's COVID-19 testing rate, the percentage with at least one vaccine dose, the percent of fully vaccinated people, the COVID-19 case rate at the start of the at-risk period, and which national COVID wave was the county's first wave. So now I'll move on to sharing our descriptive results. So this graph shows the percentage of the US population covered by the 4 policies over the study time period. So as you can see from the graph, bar and restaurant closures had the highest implementation level throughout the pandemic. And we've combined them into one policy here because we realized that about 99% of the time, bar and restaurant closures were implemented together. So we just combined them into one. Face mask mandates were all largely implemented later on, starting in July to August of 2020. And then finally, all 4 policies dropped off significantly by May to June of 2021. So there were also some interesting findings when we compared 30 different county descriptive statistics in the high versus low policy groups. And I've highlighted just some of the most interesting findings on this slide. Overall, counties that implemented policies more frequently had a higher population density, a higher percentage of service job employees, a lower percentage of work from home employees, a lower percentage of Republican voters, a higher percent of people living in housing with 20 or more units, and also a higher COVID-19 testing rate. And this slide displays a county level heat map illustrating regional variation in policy implementation, where red represents a high policy intensity and yellow represents low intensity. And you can see that in general, counties in the Northeast and Northwest had more days with policies in place, and counties in the Southeast and Central Plains had fewer policy days throughout the pandemic. So now I'll just move on to the impact evaluation results. So across all 4 waves combined, high policy implementation counties were associated with a lower hazard rate for every single threshold, and these results were all statistically significant. And these results are most apparent in waves 2 and 3, and less apparent in waves 1 and 4, which I'll touch on later in the discussion. So the Cox regression results for the continuous version were also similar. We see that all 4 waves combined, a 1-day increase in the policy is associated with a lower hazard rate for every single threshold. And again, we see that the results are most apparent in waves 2 and 3, and less apparent in waves 1 and 4. So overall, the different policy effect strengths across waves reflects the timing and prevalence of policies and also the presence of mediating factors that influence COVID-19 transmission at different times during the pandemic. So at the beginning of wave 1, there was confusion about the seriousness of the pandemic and about clinically important virus characteristics and a lack of specific early CDC guidance. So these factors contributed to a delay in policy implementation and caused many counties to implement policies after already having an outbreak rather than proactively to prevent an outbreak. And reduced mask availability in the early stages of the pandemic may have also made enforcement more difficult. So these early difficulties are likely the cause of the lack of statistical significance for the lower thresholds that take place earlier in wave 1, while the significance at higher thresholds may reflect longer policy exposure by that point. So wave 4 was also unique for several reasons. By the end of wave 4, 54% of the country had at least one vaccination shot, and 78% of older adults had a complete vaccination series. So as you can see in this exhibit, many counties dropped their policy mandates during wave 4, but the dropping of the policies was not at random. So counties with higher COVID-19 levels were more likely to keep their policies in place, while counties with higher vaccination rates were more likely to drop their NPIs. So this selective revocation can lead to reverse causality, where higher policy levels are associated with higher COVID-19 transmission, as we can see for the low thresholds in wave 4. So there was also a significant amount of pandemic fatigue at that point, which is based on a lot of survey data research, and that led to much lower rates of policy compliance. So overall, our stratified wave findings highlight that the degree of NPI effectiveness depends on timing, dosage, and policy compliance. So by waves 2 and 3, county officials had a better understanding of COVID-19 transmission mechanisms and the array of possible mitigation strategies. And there was also stronger policy compliance at this time, and policies were implemented more proactively. So all of these factors are likely what led to a higher level of NPI effectiveness during waves 2 and 3. So in conclusion, one of the greatest threats of rapid COVID-19 transmission is that hospitals and healthcare providers become overwhelmed with COVID-19 patients and reach their full capacity. This could leave both COVID and non-COVID patients without access to needed care and ultimately result in excess morbidity and mortality. So we believe these findings in this study provide crucial evidence in support of the use of non-pharmaceutical interventions as a public health measure to flatten the curve of future waves of COVID-19 or similar infectious disease outbreaks. So I'll just mention again that there's a lot I couldn't share here because of time limits. So if you're interested in learning more, in the publication that's coming out in Health Affairs, we've got sensitivity analyses, a 30-page appendix. So if you're interested in finding out more, please look out for the Health Affairs publication. And thank you all for listening, and I'm looking forward to answering questions later on.
Thank you so much, Courtney, for sharing your research with us. I'm actually really excited to share your work with our student working group, who, as I mentioned earlier, will be working on a similar project on COVID policy analysis. So your work is very prescient. Thank you. I can see Florence
Sounds great.
Yeah, this
Thank you.
And I'd like to introduce our next speaker, Dr. Judy Ford, who's at the University of California, San Francisco, and she'll be speaking about her research on the potential neurological effects of COVID-19. Very serious topic. Dr. Ford, we're excited to hear about your work. Please go ahead and begin your presentation.
Thank you. Let me share my screen and then hope for the best. All right. I'm going to present preliminary data. This study is ongoing. We probably have another year and a half in which to be recruiting patients for the study. And I've listed my co-authors on this work. And also I want to note my the other PI on the VA grant. The VA has funded this work through the Merit Review Grant Program. So that is Lynn Pulliam, and she's responsible for all of the variables associated with blood. So let me get started here. I'm going to be talking about neural slowing following COVID-19. It's a much bigger project than just what I'm going to show. There's MRI, there's clinical assessment, there's neuropsych testing, there's all of the stuff that Lynn does with the plasma, ApoE. But today, also it's a work in progress. I want to be sure everybody gets that. Today, I'm just going to be talking about the EEG-based event-related potentials, or ERPs. And also, just so you know, this is as you can imagine, this is a full day protocol. They come in early, they give blood, they have EEG collected, they go to the MR scanner, they do neuropsych testing, and then they go home in one order or the other. I'm just going to give you, for those of you who don't know, and there are probably plenty of you who don't, sort of the brief history of recording EEG. Almost 100 years ago in Jena, Germany, Hans Berger invented the electroencephalography. His hope was to communicate with his sister telepathically across hundreds of miles. Well, needless to say, that did not work. But the technique was picked up by others because they were interested in the fact that you could actually record brain activity from the scalps of human volunteers. So about 5 years later, Hallowell Davis and Don Lindsay started recording EEG in their lab at Harvard. By the 1960s, auditory ERPs, again, ERP is event-related potentials, auditory ERPs were used to test hearing. And since the 1970s, which was actually when I first got involved, they have been used as an objective measure of cognitive function, and that's what I'm going to be focusing on today. So here is sort of a little example of how you would calculate an event-related potential. In this instance is an auditory event-related potential. Auditory event-related potentials are derived by averaging together EEG segments, little snippets, time-locked to the onset of a sound. This is a specific example of what we do with the people that come in for our study. We have a very frequent sound that actually sounds kind of like a cat purring. And then we have, that happens 80% of the trials. And then on 10% of the trials, they hear a tone, a high-pitched 1,000 hertz tone. It actually happens to be the tone that is best heard by humans, the tone frequency. And then we also have these novel sounds. They have their dog barks, horns honking, machine sounds, doors slamming, etc. And those are infrequent tones, just like the targets, and subjects are not supposed to press a button to it. They do press a button every time they hear a target tone. And so we record the reaction time to that sound. Here's an example I got from the internet that I thought was pretty good. Just imagine that the EEG is going along here on the top row, and you get a tone, you get another tone, you get another tone. And after about 40 or 60 or 100 of those tones, you cut them into little snippets over here, and you average them all together, and you get something called an ERP. This is an averaged event-related potential waveform. And if there's a dog barking, or if there's the target tone, you really get this big P300. P stands for positive. 300 reflects the time that it takes to peak, which is 300 milliseconds. This is really quick. You're really hardly aware that this is happening in your brain. And we are today going to look at the novelty P300 and the target P300. They both reflect the allocation of attention to the event. They can be either elicited passively, like in the case of the novelty P300, or with effort, as in the case of the target P300. The latency, which I'm going to be focusing on today, reflects the neural processing speed of both of these events. And again, P3 latency is an objective measure of cognitive function, how quickly that cognitive function happens. Again, we press a button and we get a reaction time. The reaction time is kind of a dirty measure, if you will. It reflects not only the neural speed of how long it takes you to make that decision, it also reflects the motor speed that could be slowed down by any number of things, including, difficulty getting to the button, difficulty finalizing that decision, etc. So we have the P300, and that's an objective measure of cognitive function, and then the reaction time, which is a combination of both of those two things. So for our study, and again, this is ongoing. So far, we have collected data from 39 people that we are considering neuro-COVID. What does it take to be in the neuro-COVID group? We ask them these questions. Compared to before you got COVID, is it harder to concentrate? Is it harder to remember things? Are you more depressed than you used to be? Are you more anxious than you used to be? If you say yes on any of those questions, we put you in the neuro-COVID group. We also have a smaller group of people that we are considering the control COVID patients. These are people who have COVID, have had COVID, but they have not experienced any of those four things. And then because we weren't sure whether we could actually collect data from anybody who had never had COVID, we have another group of people that we call the legacy controls. These are data that we collected on that paradigm I just showed you at Yale before the pandemic. And there are 83 people in that group. So we have the neuro-COVID group who have complained of one of these kinds of neurological things. We have the control COVID group who had COVID but don't have any complaints, and then the pre-pandemic legacy controls. I just want to point out one important thing, and that is that the legacy controls are a little bit older than the neuro-COVID and the control COVID patients. So we have statistically removed the effects of normal aging from the COVID subjects using Z-scoring, but I'm not going to go into that. The neuro-COVIDs had worse depression and anxiety, as you might expect, than the control COVIDs, but they actually performed better on tests of working memory. And we're still sorting through that. Those kinds of data. Those are data that are clinical data that are collected from the Beck Depression Inventory and the Beck Anxiety Inventory and the Matrix Cognitive Battery. So these are the data. Again, P3 latency is a reflection of neural speed. And I'm not sure whether you can see the things in my upper, sorry, in the upper right-hand corner where my picture is. On the y-axis, we have P3 latency. The slower you go, the bigger the number, and the faster, the smaller the number. So these are all slower P3 latencies than these. So right here, you can see that to the novel sounds, the neuro-COVIDs and the control COVIDs both had delayed P3 latencies compared to the legacy controls. So COVID controls, and this is something that I wish weren't true, and we've hoped this would go away, but so far it hasn't gone away. COVID controls, those are people who do not have neuro-COVID symptoms, have slower neural responses to both target tones and novel sounds compared to the legacy controls. The neuro-COVIDs also have slower neural responses, but only to the novel sounds, which is a puzzle for us. They seem to have normal speed target tones. So moving on to reaction times, the reaction times to the target tones are actually slower in the neuro-COVIDs. So despite having normal latency in your neural responses, the neuro-COVIDs are delayed in pressing the button. I'll just remind you of the picture I just showed you. You can see that they actually, it looks a little, they are not slowed down significantly in their response to the target sounds, but they do have a slower reaction time. So because they did not have any evidence of neural slowing to the target tones, the slowing in the reaction time probably reflects processes happening after the brain has registered that something important happened. So what other conditions cause slowing of P3 latency? As luck would have it, before long ago, I did some studies in aging and dementia. And this is a picture from one of those studies. This appeared in 1997. So you can see here that both the target and the novel P3 are later in older people. These are the older people. These are the younger people. So you can see, again, latency is getting longer. So the novelty P3 is later in older people than in younger people, and the target P3 is later in older people than in younger people. And it gets even later with dementia. So this makes me wonder what is going on with the people who have COVID. What is causing the P3 latency to be longer and prolonged? Let me also point out another paper I wrote a long time ago. Reaction times are also slower in older people. And the lag between when the P300 happens, between the neural decision and the time you actually get around to pushing that button, is also bigger in older people. And here's another, so I went to the literature. I remembered an old colleague named John Polich. He had done an HIV study. So he found that that people who were HIV positive also had slower P3 latencies, and it increased with viral load. And looking further, there's hepatitis. There's a literature in chronic hepatitis. P3 latency is also slower in people with chronic hepatitis. And interestingly, P3 latency improves after direct antivirals in hepatitis C patients. So this P3 latency delay that we're seeing in people with COVID, it may reflect the persistence of the virus. It may reflect actually an accelerated aging process going on. One other thing, there's been a lot of talk lately about whether long COVID has anything to do with chronic fatigue syndrome. And there have been several papers on P3 latency in people with chronic fatigue syndrome, and there's no evidence of P3 latency delay in chronic fatigue syndrome. So it's more along the HIV, hepatitis C line that you see P3 delays in these patients. So in summary, regardless of whether you have neuro-COVID symptoms, if you had COVID, you may still have slower neural responses to sounds. Now, it's not much slower, it's 50 milliseconds, maybe 100 milliseconds slower, but it's a significant slowing, and we're trying to figure out what it might mean and what you do about it. Here's one thing suggested by Courtney. Maybe you should wear a mask. Yeah, not a bad idea. Neuro-COVID patients also have slower reaction times beyond what you see in people without symptoms. So again, not sure what that means, but it is something that we do see in older people, elderly, and probably even more so in dementia. Like I said, these patterns are seen in hepatitis, HIV, aging, and dementia. And the question I ask is, is it related to accelerated aging? I mean, I hope not. Because I had COVID, and will it reverse with time? Again, we're actively looking at this. We do have information about the timing between infection and the time they were tested, and we're going to see if, in fact, the people who have a longer delay between infection and testing, whether the P3 latency will begin to be restored to its more youthful pattern. And of course, is there a treatment? And that I think is awaiting the pharmacology industry and perhaps even behavioral interventions. So the next steps, again, it's a work in progress. We definitely need to collect more data from COVID controls. This is something I keep hoping this finding will go away. I don't like the finding, but there it is, and there doesn't seem to be much I can do about it. We also are going to assess the other ERP components. I don't know if you remember that picture I showed from the internet. There are all sorts of other components. We do have data from the early N1 component that also seems to be sensitive to COVID, but I didn't have time to talk about that. We're going to look at the ERPs to the standard cat purr sounds. We used that stimulus for a reason. It seems to be its response. The response of that sound seems to be very sensitive to schizophrenia, which is what I really study. And we need to start relating all of the ERP findings to the blood data that Lynn is collecting and analyzing. And of course, we need to start relating all of this to brain structure and brain function. One of our colleagues is looking at microbleeds in the structural MRIs. Maybe that has something to do with what we are seeing in the neural slowing in these patients. Again, there's a lot to this study, and we are just this was just a tip of the iceberg. And I want to thank the VA for funding this work and all the people who participated. It's a very long day, and thank you for listening. And I look forward to questions later in the session.
Thank you so much, Judy. That's fascinating. I think given the insights that we've heard in these last two talks, this will be a very good Q&A session. I myself have a lot of questions, but I'm going to bite my tongue and instead introduce our next speaker to do her presentation. I'd like to introduce Dr. Judy Fox of the University of Virginia, and she'll be sharing her research on computational epidemiology. So Dr. Ford, or Fox, rather, the floor is yours.
Thank you, Lauren, for your kind introduction, and thanks to the to the 2024 COVID Information Commons hosts and fellow speakers, students, and staffs. I'm going today to report our NSF-funded expedition project. It's a collaborative research for global pervasive computational epidemiology. I'm Judy Ford. I'm working in the data science school and computer science at the University of Virginia. A little bit of background of this project. It's a multi-institutional project led by Dr. Madhav Maranth, and he is a coordinator PI, and we have colleagues within the Virginia Biocomplexity Institute. This is a multi-institution collaboration. We have a wonderful colleagues and researchers. It's quite inspiring experience for me. I wanted to talk about the future. That is the exciting part about my presentation today. Imagine COVID in 2025. What will we be? We want to move from the intervention to prevention because infectious disease is such a societal problem. By 2050, there will be projected deaths every year of over 10 million, and the economic impact will be over $100 trillion. Just a few years ago, we have came out of this pandemic, which in US alone, we have over 1.1 million people dead, and there are over 100 million cases. It's almost 1/3 of the families got infected. Much of this could have been prevented through better informed government policy. However, the COVID-19 is a complex data problem. First, we have non-stationary data coming in. It's quite difficult to learn and predict the trend with lack of data, noisy data. Making the infection forecasting understandable, explainable can also help the decision making. They can help to identify the important geographical and temporal focus areas so that we can signal the governments to make more effective allocation of resources to prevent the disease spread. I want to focus the rest of the talk about the research conducted in my group. We want to interpret the county level COVID-19 infections in the US. We applied the transformer AI model, which is a type of a deep learning model used by the large language model. One of the areas we're focusing on is to ask the question, why do we need prediction? The prediction using real-time data has been highlighted in 2009 by Dr. Harvey Feinberg and Dr. Elizabeth Wilson. It draws the important aspects that why it's important we want to use the latest data to study disease control and try to observe and predict. Intervention will be the action operate at the peak point, but intervention will flatten the curve ahead of the time. We use the deep learning model is the temporal fusion transformer, and this model can forecast in real time. In our experiments, we use the past 13 days to predict the future 15 days. And the data collection comes from different multimodals. We categorize them into static, covariant, and dynamic data set, like cases and deaths. But we also have some no input, such as coming Christmas and the New Year holidays. With such a model, our goal is trying to understand how to use interpretable AI to get the knowledge and information to where and when that the infection will happen. Which county are at the most risk, who are the vulnerable communities that we try to help. The journey of this study is all of this with a lot of roadblocks we need to overcome. The problems comes from that the general issue with the accuracy. How can we model, predict, so we are confident our prediction is accurate? And also, when we have this prediction, how do we explain to policymakers what are the important factors cause current rise of the cases? That requires us to have a deeper understanding of the data itself at a much finer grid level, like the county level characteristics. But we also want to make a decision at the real time so that its relevancy is guaranteed. It's very rich study because health disparity is not related just people, but also its social economic impact. We've collected over 2.5 years of data set for 3,142 US counties. And we reduced the data set features from 20 to 6 features. 2 static features, the health disparity and the population age group, and the observable features, including the vaccination and the disease spread, transmissible cases, and mobility. And we incorporate into known and unknown events so that we have a very complex multi-model articulated AI model. Let me switch to gears to show you some of our prediction results. And we compare the TFT model with the LSTM as a basic sequence-to-sequence model. And we can show that in the chart on the left-hand side, the TFT model performs the best. And they give the error message and the accuracy is higher and the error is lower. What is the underpin of understanding for interpretable AI? This comes from the attention mechanism using an encoder-decoder architecture. And the attention mechanism is the underpin of the current large language model, including ChatGPT. Because we have this multi-head attention mechanism can capture the context of the disease with the times going by. And so that will refine the space where we look at the feature and the cause and the effect. So we can focus the importance to the spatial and the temporal patterns with the hotspot areas. On the right-hand side, you can see the architecture of a TFT model. We input the past features and try to predict the future happening. In this case, it's the cases of infection. And they encapsulate embedding the features, especially the static feature, into using sequences model to capture the dependable patterns. And we propagate all these patterns to self-attention to try to mask out interpretable multi-head attention so that we can focus on the important patterns and areas. This forecasting model is able to provide us with the cyclic pattern, which is the reporting of the COVID cases, but also special time event like holidays, like weekend. You can clearly label them like in this chart. On the right-hand side, we can even look backwards, which period of time has the most impact of the future prediction in the time frame from 0 to 13 days. Here is the chart of trend. We can predict and choosing the top 100 largest counties. You can see that we have the prediction compared with the ground truth. Further, we can compare that the smaller population counties, you can see the result matches much better, has less spikes and different values. How about the location information? This chart shows on the left-hand side is the self-attention of the AI model can capture the intensity at county level. This is not possible if our data is at the state level. On the right-hand side is the data cumulative cases from CDC of all over 3,000 US counties. If you look at these two results, you can see the correlation between these two data set and the result. We measured the correlation and conclude that we can interpret the AI model by capture the self-attention weights at the county level, and so strong correlation with the model behavior versus that the prediction of the cases compared to the ground truth. Our tool provide the information that policymakers need. We believe a small reduction in the hotspot transmission can lead to a large reduction in infections, especially in the early stage. Real-time forecasting and focusing our attention on the most important regions in daily infection is crucial. We have a fine-grained method to capture those infections at county level that will significantly reduce the risk. There are many future works we can do coupled with this existing result. We can explore many social, economic impact and disparities for the future work. At UEA, we started the AI for Science program and attracted over 3,000 undergraduates to participate. And we selected a dozen students involved into our project. We want to study further the population age group sensitivity using Morris-based index study to know that each population groups who are most vulnerable of COVID infections. We choose the time series deep learning model because the attention mechanism, as Apple mentioned, can give our insight and understand how the model is predicted. There are several lessons we learned from this journey. Infectious disease has been a social, economic, global-wise problem, impact the public health and the economic at such a large scale. From the COVID-19 pandemic, our first lesson learned is that testing is vital in understanding the pandemic progress. The second is that a lot of these infections are very different in different smaller regions, and the situation is quite dynamic. The better way to address this in policy is adapted to the local level. There are many ways we can improve, including that we build the tools like we studied to accurately predict the COVID infection and the future infectious disease. That will help the policymaker to intervene in a science-based manner. Intervention is the future. We wanted to prepare, ready for the future crisis, such as the pandemic. Before I wrap it up, I really want to share with everyone that we need to build the trust if there's any lessons learned from the past pandemic. We want to improve the explanation to the public, to experts, to the policymakers, what is happening and how we can leverage the policy to impact. And we wanted to have an interpretable method to quantifiably model and evaluate our method. And we also want to explain our model behavior and AI-based predictions to non-experts, including all the public and then students. Collectively, we hope to build a future so that we're ready for the future events. With that, I want to thank you everyone for participating in today's workshop. And I provide some of our work here and please feel free to contact me. I look forward to future discussions at the end of this workshop. Thank you.
Thank you so much, Dr. Fox. That was really interesting. I want to now introduce our next speaker, Anna Johnson of Georgetown University. Dr. Johnson and her team are studying the impact of COVID on low-income students. So I'm sure this will be interesting to our students in the KIC Student Working Group as well. So Dr. Johnson, please go ahead.
Thank you. I'll just get my screen share going. Presenter view. Can you see most or all of the slide? It looks like it's at the end of the slideshow, but why not thank you for being here before I even start, right? Can you see what we need to see? All right, excellent. Okay, so unlike the presentations that have happened already, I am in a very much stay tuned. This is a preview. We're just getting started. We're in year one. I have like no actual data. So I'm excited to hopefully spark some questions because we're at the beginning. So we can be influenced by what other people think we should be looking at. And also I'm excited to make connections with students and mentors of students and just to talk about the data that we have. We're building on an ongoing study. So we do have a good amount of data. It's just not the data that's relevant to the KIC. So the title of my talk is From a Longitudinal Pre-K Evaluation, parentheses, irrelevant to COVID, to a study of COVID impacts on child development. And I'm Anna Johnson. I'm an associate professor of psychology at Georgetown University. And I will, of course, start by acknowledging our team and study partners. So the first part of the study, the part that was focused on pre-K, was funded by the NICHD and multiple foundations. And then we got NIMH funding to fund the COVID part, which is the kind of prospective future part of this. And I'll make those two legs more clear in a moment. But I have both current and former co-investigators. I'm the PI of both the original NICHD study and the NIMH study, but of course we don't do anything alone in science, and for good reason. We're definitely stronger together. So my co-investigators are Deborah Phillips from Georgetown University, who's emeritus now, Seth Pollack at University of Wisconsin-Madison, and Gabby Levis-Stein at UT Austin, Diane Horm at University of Oklahoma Tulsa, and Gigi Luke at McGill University also were co-investigators on the earlier part of the study. And this is a research practice partnership. So very, in many ways, unlike some of the presentations we've already heard, like this is very applied research. So we are partnered with the largest public school district in Oklahoma, which is the Tulsa Public Schools, and also with community programs that provide services to low-income individuals in the community. And that's the Community Action Program of Tulsa. They administer 8 Head Start locations. Head Start is a free early childhood program for families whose incomes are at or below the poverty line. Also partnered with Tulsa Educare, which is very similar to Head Start in its model, targeted to families in poverty with little kids. And we're partnered with the Oklahoma State Department of Education. So here's some context about the actual study and what I mean by kind of like the first chapter and the second chapter. So the study is called the Tulsa School Experiences and Early Development Study, or Tulsa SEED. And we started in 2016 when children were 3 years old. So we sampled low-income children from low-income communities attending early childhood education programs that exclusively or predominantly provide services to families with poverty level incomes. So children that we sampled across those different partners that I just mentioned in Tulsa were 3 years old in 2016. And this first part of the study was funded to follow them through 4th grade, which was, last year, the calendar year 2023, which just ended. We sampled approximately, 1,300 kids. We're still following about 1,000 of them. Some of them have left the state of Oklahoma. We're not able to track them anymore, but if they're still in Oklahoma, we're still following them. And every year from 2016 forward, we do what we call a 360-degree data collection. So this is surrounding the child and all the kind of primary caregivers the child comes into contact with, both in school and at home. So we directly assess children using a bunch of NIH kind of approved measures like paper and pencil measures, maybe some of the neuropsych measures that the first Judy Ford talked about, neuroeducational measures, psychoeducational measures, math, literacy, language, things like that. We also administer measures of executive functioning directly to children. And then we observe their classrooms. We use validated instruments to observe the quality and measure the quality of their classroom experiences. We interview their teachers and collect data about the teachers. We interview the parents, and then we scrape data administratively from the programs, school, district, and state that the children attend. And so we've done this every year from 2016 forward. Of course, what happened in spring of 2020, when our kids were 2/3 of the way through first grade, is that COVID closed schools. And in Tulsa, as in most of Oklahoma, despite being a red state, they actually closed their schools and stayed closed and did remote learning for almost a year and a half. So kids spent almost all of second grade in remote school, and then returned to the classroom in the fall of third grade, which is the fall of 2021. They just completed fourth grade last year and are now a few months into their fifth grade school year. So the study sample, just to give you a sense, this was, again, designed to be a study of low-income students and their long-term development. Those 360-degree measures that we collected, again, not necessarily really relevant to the KIC environment, but as a developmental psychologist who studies education policy, we were measuring things so that we could capture the effects of their early education experiences on their later outcomes. And it was designed to be a sample that informs public education policy that is particularly relevant for low-income and minoritized and marginalized youth. So the sample reflects the purposeful sampling technique. It's a majority non-white sample. It's about 80% Black, Hispanic, or Native American. So we have adjacent tribal lands in Tulsa. So we have a decent Native American size population. 11% of the sample is white, and then a multiracial or other race ethnicity category. We have about 50% of our sample is dual language learning, mostly Spanish speaking. And as designed, they are all low income households. So their household incomes are mostly at or below the poverty level. So this is the first part of the study. This is how the study was designed. We were collecting these key constructs, trying to understand how children's pre-K education experiences when they were 3 kind of explain their long-term outcomes into upper elementary school, and measuring these mediators and moderators and classroom context experiences, and trying to essentially get this big perspective on child functioning. And these were our primary measures for this study as it was planned. And then school closes in first grade, and we decide we have to keep going with this study, and we have to start to see what we can say about the effects of COVID on children's learning environments. And what was obvious to us right at that moment was we have this unique ability to talk about resilience and what so many people in education policy and public health have talked about learning loss and response to school closures, but you can only really track trajectories post disaster if you know something about what the kids were doing before. Or else you are maybe making some assumptions about, like kids who might have already been in crisis are continuing to be, on the edge. So we had this unique ability to use multiple waves of pre-COVID data to understand which kids were on a trajectory of success, which kids were on a trajectory of struggle, and how did this unforeseen, massively disruptive event that closed their schools and put many of their families into crisis affect their learning and emotional, social, executive functioning, et cetera, outcomes. So we pivoted during COVID and immediately started collecting data on families' experiences of disruption. So we had already been interviewing parents and teachers. We added items about, loss and change in terms of family members, health status, income, employment, household size, things like that. And so we've produced a few publications that were kind of rapid response, designed to understand, for instance, predictors of both parents and teachers, depression and food insecurity, during COVID-19 distance learning. So we used the data we had during COVID to try to get some information out there. What predicted what first grade teachers did when they had to pivot to online learning? Were the teachers who were rated to be very good instructors in a classroom when classrooms were in person also very good instructors when they took their instruction online? What were the barriers to participation, particularly for low-income and Latinx families? So we tried to, really build up what we were collecting on COVID so that we could say something meaningful about the impact of this massively disruptive event on children and families. And we tried also, to put out kind of newsletters and fact sheets and briefs and things that might be a little more digestible for a popular audience, for policymakers, and reported, on families and teachers' experiences during school closures and how that might affect certain marginalized subgroups who are intersectional with race, ethnic minority status, such as those with special needs, overrepresented in the poverty population, for instance. We tried to reframe this language of learning loss. So there's, like I said before, a lot has been made of, learning loss. Well, loss can be defined different ways. If you don't know where you came from before, how do you know if you've lost or just continued to be lower performing, right? So we used our rich pre-COVID data to talk about how you might define learning loss, and why we might see bigger losses in math than reading, for instance. So somewhere in 2022, our other funding allowed us to continue doing our pre-K evaluation research as we had planned, but we also had this moment to kind of propose a new study. And that's where the work that I'll hopefully be able to come back in another year or two and talk about really comes in. So we added measures and wrote a new grant, which is just in its first year right now, to measure COVID disruption, both during school closures, which we had already kind of started to collect under our original project, as well as family disruption that we expect to have continued after schools reopen. So I think everybody understands that COVID is not over. There's kind of this long shadow. And so, what has it done to families who are already in situations of instability to, continue to have, interactions with COVID as it kind of has not gone away in our lives. And then we added this dimension that I've highlighted in green, protective factors. So we also recognize that some families have bounced back more quickly than others. And some families are showing surprising patterns of recovery. Some children are showing, surprising patterns of recovery despite all of these obstacles. And so we added these new measures that we started collecting just this year, of what we might think of as protective factors that would help children bounce back more quickly from the disruptive effects of COVID at the family, school, and peer levels. And so the model that we're kind of testing is not mine. It's Ann Maston, who's a developmental psychologist and resilience researcher, has proposed this idea. I added the word COVID, but this idea that, there's an acute trauma or disaster that sets children who might have previously been on varying paths of development into wildly different paths. So some of them may experience survival, which is kind of continuing. Some may experience thriving, and some may kind of succumb to the effects of COVID. And we're really interested in this zone of recovery, like what is explaining in these post-COVID waning years which children are following which path. And because we have lots of data from before COVID, we can draw the whole line, and really understand what's going on. So I know I'm pushing up on my time, so I'll just say that these are the data we've collected all the way along, the data we've added, and the data we'll add and continue to collect. Our original project focused on that first window. We're picking up there, and going forward, we now have funding to follow children into 10th grade. So the study will have gone from age 3 to 10th grade, and will allow us to test these questions about whether COVID disruption impacts child functioning, whether pre-COVID child functioning kind of moderates the association between disruption and post-COVID functioning, and whether disruption has a long-term effect on children, and whether that long-term effect can be moderated by these protective factors in children's school and home environments. So that is stay tuned. I hope to have more to say. The title of the study is Succumbing, Surviving, and Thriving, the Development of Low-Income Students in a Long Shadow of COVID-19. And I look forward to updating you on our findings as soon as we have more of them.
Thank you so much, Dr. Johnson. We're looking forward, I think, to hearing more about your longer research findings. Maybe you'll come back for another KIC webinar at some point. That would be great. I want to quickly introduce us all to the next speaker this afternoon, Jay Shenoy, who works in R&D at ONI, which is an AI cryptography and decentralized computing company. Jay will be talking with us about ONI's NSF-funded research on patient privacy.
Thanks, Lauren. Let me get the slides up. So, yeah, my name is Jayvant, and I'm an engineer at ONI. And today I'll be talking about our project on scaled analysis of medical records with the funding from NSF. So the problem is that medical records are very rich in information, but we don't have a good way of studying them at scale. Traditionally, studies happened in individual hospitals on records within that hospital. And even there, it's laborious with residents and students manually transcribing data into spreadsheets. This process is also really slow. In situations like COVID-19, this is unacceptable. We don't want to wait until one hospital has enough data for statistically significant studies to happen. And that's what wound up happening. That's what winds up happening usually. But we really want to get results at early stages of the spread. And for that, we need to be able to do studies across a number of hospitals in aggregate. There are really basic questions that you'd think would be easy to answer in this day and age, but they were not easy for COVID and still aren't even today. For example, does blood pressure medication improve or worsen COVID? Tens of millions of Americans are taking these blood pressure medications, so you would think that this would be an easy question to answer just based on looking at outcomes for patients who take blood pressure medication and wound up in the hospital with COVID. It should be as simple as a Google search query, but it's not. So our goal was to enable rapid research over medical records across a number of healthcare institutions in an efficient manner and without sacrificing privacy. With our tools, healthcare institutions and pharmaceutical companies can reach statistically significant populations much quicker, and research can be conducted right away. It's also more secure. So can we get the best of both worlds? Can we get a huge pool of data for research and at the same time maximize security? Yes, we can with this cryptographic technology. So this technology to achieve this goal is called a magical technique called secure multi-party computation. This allows a set of parties to jointly compute a result over their inputs without revealing their inputs to each other or anyone else. One example of this is called Yao's millionaire problem. Andrew Yao introduced this in 1982, and it's where two millionaires, Alice and Bob, want to know which one of them is richer without revealing their actual wealth. So you have two people, Alice and Bob. They each know their own wealth, but don't want to tell the other person. And let's say they don't want to involve a third party, so no IRS or anything. Can you think of a way for them to figure out which of them is richer? Well, believe it or not, it turns out there is a way to do this. And as another example, let's say we want to calculate the average of social security numbers of everyone in this webinar, but we don't want to reveal our social security number to each other. Is there a way we can do it? Yes, there is with the secure MPC. We applied the same concept to health records, and the result of a query is computed across multiple hospitals without the hospitals needing to transmit or reveal any records. We demonstrated this across a few disparate sites in our project. Here are some of the examples of queries one might be interested in asking, like the average length of stay in the hospital for patients over 70, or what percentage of very young patients wound up on a ventilator. For a more cryptographically savvy audience, we used a mascot for MPC technique. I won't go into the details now, but you can ask me about this later if you're interested. The only thing I'll mention here is that this protocol is secure against dishonest majority, which means that this protocol is secure even if a majority of the participants are malicious. I want to reiterate that with our approach, no data ever leaves the hospital. Each data's hospital is completely siloed. IT departments really like this as they don't have to worry about security. Not just that, nothing can be reverse engineered. And coordination of the computations is via blockchain or distributed ledger. This framework also enables more equitable clinical trials. Traditionally, patient populations in clinical trials have not been very diverse. One of the priorities of FDA and others is to improve that. And with this technology, sites with patients of interest can be located, even if they're not institutions a company typically works with. And since then, we have extended this approach from querying to training AI models across disparate sites in a privacy-preserving manner. We are also working with the NIH for privacy-preserving drug discovery. Our end vision here is to have a privacy-preserving intelligence network across biomedicine. Thank you for listening, and I would like to thank KIC for this opportunity and NSF for funding this project, our collaborators across the country, and my colleagues at ONI. Please let me know if you have any questions at the end of the session. Thank you again.
Thank you so much, Jay. That's really interesting. I love the array of topics that we've had across this single webinar, lots of different fields that we're touching on. And now I'd like to introduce our final speaker of the day. I know it's been a long haul so far, but I'm very excited about this presentation from Kazushika Yokoyama, who is of SUNY Geneso, and Dr. Yokoyama will share his research on 3D imaging systems.
Great. Thank you very much for your patience, and I hope you can see my screen here. Okay, so my talk is focusing on chemistry, and I hope it's not going to be too boring for all of you. I'm going to focus on the study which we did for the spike protein of the SARS-CoV-2 virus, and that's the icon of the coronavirus, has like a corona spike-like formation. And I'd like to acknowledge first that my group and those who involved heavily with the bold font, and I'd like to thank for NSF, especially for the major grant. So talking about the spike protein, I want to show you the animation showing the part of the spike protein which has a S1, S2 domain. Left-hand side, I'm showing the process which is going. So S2 comes in as a receptor that take off the S1 part. Then now the S2 part is going to anchor on to the human membrane. Then they are going to fold back and merge the virus cell and also the human cell together, and then spits out the RNA into the human body, then infected. And this is the intro of the infection. So spike protein makes a huge role to start the infection. And also, as you may have heard, that the mRNA vaccine basically ask human cell to copy the spike protein and train us to have the antibody to fight against it. So spike protein can be a little bit of the behind the scene, but it's very interesting thing to talk about. And methodology that I like to use here is, since I'd like to focus on only spike protein, I don't want to think about the rest of the virus part. So simply just try to anchor or place the spike protein on the some particle. In this case, I'm going to use gold nanoparticle, gold particle, and has the two parts, part which is accepting the H2 and also taking off the this S1 part out, and then the S2 part is the fusion protein part that you saw in the animation. It's going to go onto the cell and try to merge. Now, the first question, of course, is does this spike protein attach onto the gold surface? Nobody knew, so that I took the microscopy, which uses the electron to probe the object. Then, as you can see, it's a very fuzzy thing, but I'm so excited to see this. So if you focus on the left-hand side and look at the edge of this gold nanoparticle, it's a dark sphere, then you see a very fuzzy part, which is spiking out definitely. So it's really obvious compared to the case when you have acidic condition, then two things happens. Number one, that if you take a look at the surface of the gold nanoparticle, there's no fuzzy thing. So it's actually acting like a sheet. And at the same time, they are trying to make friends with the other nanoparticle, and they try to attach each other. So they're making interactions. And that's actually a cue for the next point that I'd like to make. The reason why I am so interested in doing spike protein is the thing that we have the paper that showing, reporting that the spike protein is making amyloidogenesis. It's making fiber. So it's similar to what you observe in Alzheimer's disease. In that case, amyloid beta is the major thing that the people think is a cause of the fiber. So that is the reason, the major motivation. So now I'm sure that you are asking why I want to use gold nanoparticle. Here is the first reason why, because it has a color, so that I can actually monitor what's going on. For example, if I can use the example for A beta 140, that's the iconic protein for Alzheimer's disease. Then for pH 7 or pH 10, so either neutral or basic condition, then they don't want to make aggregates. They just want to keep the structure of the protein as folded, so they are not welcoming to interact with each other. And it has the color of the red. However, if you make the pH 4, which is acidic condition, then we can control the structure of this protein. They unfold, and then they're going to welcome or invite other protein, and they start connecting gold core to each other. So you can see that the chunk of the aggregates here. Then the color also changes into blue. So by looking at the color of the solution, we are able to tell what's going on the protein on the surface of gold. So that's the huge advantage. And also, another thing is, I want to show you that this example, this is the very artistic thing, but this is actually coming from the gold chloride aggregates. So gold chloride aggregates, which has the amyloid beta on the top. And my point here is that by creating gold chloride aggregates, we are able to make the stage to detect something which would contain protein-protein interaction. In other words, if there's no interaction between protein, in this case, spike protein, then you won't see the aggregates. So that finding gold chloride aggregates, this chunk of particles, that's showing that we have something to study about protein-protein interaction. Okay, and this is a little bit busy, and I'm hesitant to sort of go fast, but what you're seeing here on the left-hand panel is, it's like doing the experiment. So this is what exactly we did. So we actually add acid or base externally and making the pH condition either 4 or 10 back to back. Why we are doing this? Because we want to see if the protein called aggregates can make a reversible, either make aggregates or disassemble, so that we can, if we can control the structure of the protein on the top of the gold. So in this case, we see that things are actually going quasi-reversible, and we can actually plot that the peak, it's not exactly reversible, but we can see it's going back and forth. And this video is not really synchronized with these panels, but they're actually showing the idea. I think it gives you an idea what kind of color you will see. So this is great. So this is what we probably expect to see if the spike protein is attached, and also they perform the same way that amyloid beta 140. So here's the result for the spike protein. So I am plotting the peak shift. So as you can see, a lot of go back and forth. And in this case, if you're wondering, I'm showing lots of the waves here. So it actually has a label of D from 10 to 100 nanometers. So what I did here is I changed the core size of the gold nanoparticle and see if there's a certain threshold that they start making this reversible process of aggregation. And you can see that clearly between 20 and 30, there's a difference, so that it has the point that the spike protein seems to attach and then make the reversible process if the size of the core is larger than 30 nanometers. From the report, as far as I know, the size of the spike protein overall is reported to be 100 nanometers. So therefore, the spike protein, I think, reported to be about 10 nanometers. So I think the spike protein that we are seeing is a case that the corresponding to when D equals 80 nanometers, there's a 10-10 spike sticking out. Now, my point here is I'm so excited to see that the spike protein can be able to make aggregates. That is actually the reason why I wanted to study, so that it has the good stage that we're able to study how they are going to make interaction and leading to the fibril. Now, so that's pretty much the thing which is done. And then the rest of the 3 or 4 slides, I'm going to talk about study in progress. I have 2 questions to ask. Number 1, I know now that the spike protein called gold can make aggregates. That's good. However, how spike protein dissolves on the gold surface? What's the first stage to go into the nanoparticle? And then question number 2 is, then what is the structure or like a conformation of the spike proteins when they're forming aggregates? For that, I recently published a paper which talks about amyloid beta 140 reaching to the gold surface, and it actually revealed that benzene ring contained part of tyrosine or phenylalanine approaching to the surface. And then after that, beta sheet formation is used to networking the protein. So that could be maybe the hint, or maybe could be the answer for the spike protein case. And for that study, I used this called, it's kind of confusing, but it's not SARS, it's a SIRS, surface enhanced Raman scattering imaging. This is basically image then very uniquely by using the Raman signals. So this is another reason why gold nanoparticle was used, because it has a huge signal on the top of the gold surface. So very quickly, I just want to talk about the preliminary result. When I have the spike protein called the gold colloid and trying to see the Raman imaging, I was successful to get the Raman imaging. Like a thermal camera, if you see the people, then you have a different temperature, different color. I'm actually showing this thing as a spectroscopically different color corresponding to different component of spectrum, so that you can actually image the particle. This is the gold nanoparticle aggregates with spike protein. has different component. And I am successful to find out that some of the part which is around this region called the fingerprint region. It's well studied. We know what kind of motion of the molecule is going on, but I'm more interested in the part which is not well reported. This is the part that I'm trying to study harder. And also it's possible to make a three-dimensional slice of the spectrum and being able to find out the particular section of the networking or not networking part. And also, lastly, you are able to make the mobile section of the spike protein by adding the ACE2. So this is the trigger of the infection, and then you are able to make the what we call the aggregates to be mobile because of the ACE2. So that would allows us to study which section of the spike protein would be mobile. So this is just trying to show you that the video and also the image. So I can actually tell which part of the color corresponding to the mobile sections. Sorry, I'm going too long, but this is my conclusion. So I have three conclusions. Spike protein likely adsorbs onto the gold surface, and also spike protein called nanoparticle can form aggregates, can be used for studying further details, and also by adding the ACE2, able to create a different set of the study to find out the mobility of the spike protein. Thank you so much.
Wonderful. Thank you so much, Dr. Yokoyama. This is really fantastic. And I want to conclude the series of presentations by thanking all of our speakers for sharing their research with us for today. And to the audience, I'm going to share my screen briefly to let you know that each of our speakers' presentations will also be made available on our website and on our YouTube channel, hopefully later this week. Written transcripts in English, Spanish, French, and now Hindi. We're adding this fourth language to our repertoire with help from our students at Columbia. These transcripts are generated by our students and will be done in the next few weeks as part of our ongoing accessibility and multilingual resource initiative. So you can find copies of all 140 about talks to date on our website, and I can share the link in the chat to where you can find all those materials on our website. And before we segue into the Q&A of today's webinar, I'm going to briefly plug all the ways that you can stay in touch with the COVID Info Commons. So please check out our website. You can subscribe to our newsletter. You can follow us on X, Instagram, Slack, or LinkedIn. If you have any questions or suggestions for events like this, you can always email us at info@covidinfocommons.net. I'm going to share all these links in the chat, so please feel free to peruse our channels at your own pace and keep an eye out for communications about upcoming KIC events. And so now that I've done all this admin work, I'm going to hand it over to Florence for the fun part of today's webinar, which is the Q&A session, to close us out.
Excellent. Thank you, Lauren. And that was fun. I learned so much from all of you whenever we do these things. And as Lauren said, we're very lucky to have such breadth and depth of research, and it all applies to COVID. Everything we do now applies to COVID, unfortunately, since it's the new environment, the new gas that we have in our environment. So what I would like to do now is go to the Q&A, and we've had some questions come in. And Miranda, I see that you just put a question there. Miranda is one of our stalwart researchers that's been involved with the COVID Info Commons for quite a while. Miranda, would you like to ask your question, or would you like me to ask it if you're not in a place where you can talk?
Actually, I'm fine. Thank you. And I want to thank all the speakers, of course. I had a specific question for Dr. Yokoyama. On your slides where you were showing those nanoparticle, sort of the set that ran from like 10 to 100 nanometers, there was some very interesting behavior for what seemed like the ones towards the middle of the range of those, where there was larger amplitudes, and then they
Yeah.
sort of like abruptly kind of became
Right.
smaller in amplitude. I was just wondering if that was sort of due to anything in the sort of physics of the system, or if that was just sort of an artifact of measurement.
Wow, you are really paying attention to the thing. I'm
I'm
surprised. Yes.
also a
Yeah.
chemistry person, so
Oh, no wonder. Yes. Thank you so much. So that was first we thought some irreversible thing, but it actually happened every time we try to keep the condition the same. Here we have to be careful that we actually you actually saw that process is adding the pH 4, pH 10, vice versa, so that we try to ignore, actually we try to minimize the human factor, which is like the time. So the amount and the value of pH try to be the same consistently for the entire different range of the D. And we still see the same thing. So right now, what we actually think is, and just let me say that we really don't know what's going on yet, and waiting for the Raman study. But I think it happens always either like 8, 9, 10, operation number 8, 9, 10. That corresponds to about 25 or 30 minutes. And so looks like there's a certain thing happening that is the maybe changing the conformation of the spike protein. There's a report that there's an up and down part of the spike protein S1 part. That could be the one thing. And also another, I don't have an answer, but another interesting result we had, I didn't show it here, but we tried this with the Omicron case. So the one that we did is the alpha. So Omicron case, they say that it's very invasive, so that we kind of thought maybe we might see the different type of behavior in this up and down pH hop thing. Then we saw it. And it was very, very dying. It doesn't really go to the sort of undulations. There's no like a binodal amplitude thing. So it didn't happen for the Omicron case. Now, one more thing, when we did this with the ACE2 adding to it, ACE2 add and then did the pH up, we saw extremely surprising result, which is like, so when it goes to from 8, it goes back and forth, then starts undulating the bigger after the 8. Then when you add ACE2, it reverses. So that the amplitude was very small up to 8, then start increasing after that. So I think that's actually matched with exactly the point where the amplitude changes, discontinuity. So therefore, I think this is another good supportive evidence that something must be happening.
yeah,
And
no,
that
it's very
something,
interesting.
yes, happening would be like time is like 25 to 30 minutes.
Wow, very interesting. Thank you.
Thank you for noticing that. I'm surprised that you looking at
Very interesting work. Thank you.
Thank you so much.
Yes, we're very fortunate. We have brilliant people in this community and they show up and ask really good questions. So, and we love all of your presentations because you're making us all think, so what does that mean? And the ongoing uncertainty that we're bumping into when we go around the corner and in the night, with this COVID stuff is, hopefully going to help us find sites that will help for the future. So we have a couple of more questions. Thank you for the question, Miranda, and thank you, Dr. Yokoyama, for the answer. Kao Aize, if I said that correctly, I'm not sure, from Mahari Medical College.
Yes, that's correct. Thank you so much. I learned a lot. It's a lot of nice word. So nice word. So I have one question, Dr. Ford, and one question for Dr. Sunny. It's a very quick question. So Dr. Ford, it's really nice work. So you talk about compare the neural and cognitive consequence compare with the patient who has been infected by COVID-19 with people who never has COVID-19. So I'm just curious how to consider the confounding factor that the people who has been infected by COVID-19, their cognitive neural progress before they were infected by COVID-19, what's the baseline of these patients? Right? We know that there is it looks like on your side you see difference after they were infected, but I don't know if in the baseline they also have some cognitive problem, cognitive behavior problem.
You're on mute.
There we go. Thank you for that. That is certainly something that we worry about. We do have information about their what kind of occupation they had, their status in the community. So we do have that kind of information. What I would guess is sort of based on their neuropsych performance, is that they are just as high functioning as anybody else. In fact, quite often they are above the population norm in terms of their neuropsychological functioning. And what we do, I think it's important to realize that the way you get into the neuro group is you are yourself saying whether you think your memory is worse, whether you think your concentration is worse. And what we're actually seeing is that it's not bad. The people who think it's bad, it's not. It's not bad. Of course, we don't know what it used to be, but it is not bad. In fact, it's typically a little bit better than everybody else. And so we have occupation. They are not different in terms of occupation, pre-COVID occupation, but that's about all we have to go on. We don't have any information about them as far as how what their cognition was like before they got COVID. And it's a real problem. Be great to know.
It is true. Thank you so much. I have one more question for Dr. Shen. Seno, so you mentioned that you are working on the secure multi-party computation system. This system seems very similar, like the very close to the Odyssey. It raises observational data. It is so Odyssey is a kind of common data system, and I don't know, is that you're kind of querying the data from different hospital, right? So each hospital has its own privacy. And do you consider to use common data format or similar like Odyssey, what they have been doing?
Jay, I think that's for you. It's a security party computation question. So Kao is asking if you're using data like is in Odyssey. I don't know are you familiar with the Odyssey?
No, I'm not. Oh, what does it use?
Odyssey is and
make sure we're both the same.
yeah, it's called observational health data science and informatics. So it's a kind of community, and people has been working on develop common data model, like all of us is using OMAP. So it's kind of like you preserve your own privacy, but all of different institutions using the same common data. So when you query, then you don't need to verify, to modify your query. Just like you use common tools to go to common data site, but each site preserve their own privacy. I don't know if you consider this component or something like this.
I haven't come across this, but it seems like this might be using some sort of federated learning. It is similar, as in it is a distributed protocol, but it's not as secure as multi-party computation. With multi-party computation, you have some cryptographic guarantees that you won't get in federated learning or similar processes. But I'm not sure what exactly they're using, so I can get back to you on that.
It's good to know. Thank you. I
But
was
yeah,
just
so
wonder if you're familiar with that. It's good to learn. Thank you so much.
with multi-party, there's a lot more guarantees.
It's kind of
Yeah,
worrisome.
you can also reverse engineer the data. If something leaves the hospital, like some kind of data leaves the hospital, you can, even if it's not the actual data, um, um, eavesdroppers can, look at it and reverse engineer the data.
Yeah, and I'll drop a link into the chat too. When I used to work for Indiana University, at the NSF Cybersecurity Center of Excellence, and Abby, you'll be next. We did some work with Mayank Varia, who's a professor at Boston University, and he's been working on secure multi-party computation for quite a while. And so it can be applied to many different areas. It's very interesting and a lot of fun if you're a cybersecurity person and a data scientist. It's like the best of both worlds together. So I just put an example into the chat that actually explains at a high level what it does. Jay did a great job of explaining how it works in medicine as well. And I think there's a lot of opportunity to apply it in more ways. I just think a lot of people don't understand what it is, and it sounds so complicated you can't even explain it to people. But it is very powerful. And actually, I hate to say it, Jay, but it's actually rather simple when you actually understand how it works, even though it's very powerful.
Yeah, I think in one of the slides I have a one example for additive secret sharing. I think that is probably one of the simplest explanations. Yeah.
Yeah, it's really great. So I hope you might not see it more, but I hope it's underneath things more.
Yeah.
I don't know how obvious it will be, but hopefully it'll be deployed even more. Thank you so much for that. Abby, I think you had a question. Ooh, where did you go? You moved. Oh, there you are. Oh, I think you might be on mute.
Okay, I have my questions are the same two people. I'll start with Jay if that's okay. I was wondering because I've been reading the newspapers and stuff there, and you say that your model is protected against malicious users, but does that mean does the malicious user, do you define that as someone trying to steal the information or someone giving you bad data?
It can be either. So there can be malicious users who are trying to steal data. Like these are usually man-in-the-middle attacks. Like they're trying to see what I mean, if not data, like whatever is coming from a party to another party when they're transmitting. So that is one type. And another type, as you mentioned, can be a participant itself. They're trying to give fake data just to throw off the statistics. So there can be both. And depending on the protocol, there are many ways. There are types of protocol which can be secure against either or both of these vulnerabilities. But with Mascot, it does have protection against both. Yeah, when they say dishonest majority, one is, I mean, it says that like, let's say there are three or four participants, and even if let's say four participants, even if 3 out of 4 participants are not honest, as in they are providing fake data, the data of the honest participant is still protected, as in it does not leak. And in that protocol, there's also a notion of abort. That means if any of the participants do not follow the protocol, then the whole multi-party computation is aborted right when they don't follow the protocol.
Okay, but you said you're also trying to look at your training AI
Yeah.
using it. But how would you, if you, I'm making a couple assumptions here. And I have a limited knowledge of AI. But let's say you have a malicious user who is giving bad data. How, and for whatever reason, I don't care, how would you prevent, and someone finds out, how would you even be able to correct it if you can't tell that, if all you know is that there was bad data put in, you can't reverse it? Since you can't trace who it was to, you just know this is bad data, somehow it got in here. Is it even possible to correct since it's source protected?
Yeah, so these protocols, the mass call protocol is a little bit more intense computationally. So that is usually not used in AI related tasks. But we can use some other protocols like speeds that are a little bit less intense. So speeds is an honest majority. So it's not protected against malicious adversaries, but malicious parties. But in case of the problems that you mentioned, like someone trying to throw off, like they're giving bad data. So things like blockchain and zero knowledge proofs can be used here. Zero knowledge proofs can help to make sure that computation is done correctly by any parties, and blockchain can be used to make sure that the party is using the right data or the correct data. So they can set up like smart contracts to make sure they can commit to a data. So they can say, okay, this is the data set I'll be using and using for training. So they can commit to the data before they actually train it. And after they train it, they can then prove that, okay, I did this type of training with this data, and that helps make sure that these problems don't occur, or if it occurs, we can catch it.
Okay.
Yeah.
Thank you.
Yeah. Thank you.
Now, my next question, I believe, is to Judy. You say you work with your specialty is schizophrenia, and you also said that you don't have the cognitive function pre-COVID. And you also said that your participants are self-reporting their symptoms. Are these people potentially long COVID, or are they not? And also, are any of these people potentially neurodivergent, or have any auditory issues, or did that affect your process, or are these individuals screened out or for later study?
First of all, thank you for allowing me the opportunity to correct what I said. Caitlin reminded me that, in fact, we do have measures of what we call pre-morbid function. We know we have these measures that do reflect how well somebody did intellectually before they got COVID. And I just did a quick statistical test of it. And the neuro-COVID subjects are no different from the regular COVID subjects. So they start off at the same baseline level. And are we waiting for them? Are we waiting for the COVID subjects to develop long COVID? No.
Are these people who are your neuro-COVID people who also say they have long COVID? Or are these people who or just feel that they just have this COVID symptoms that are just kicking their butt still, like the people who say they have long COVID, they're dealing with long-term side effect issues?
They have responded to an ad looking for people with long COVID, and we outline what some of those symptoms are. And so they call in, and we screen them for other things that would rule them out. For example, serious mental illness, for example, would rule them out of the study. So Yeah, they think they're coming in for long COVID. The people who we call the COVID controls, they actually are coming in through another pipeline of recruitment. When we are looking for participants for our other studies in the lab on depression, bipolar, and schizophrenia, and we're looking for healthy controls. And when we find out that they had COVID, we ask them if they would like to be part of this study. So they do not think of themselves as having long COVID symptoms.
So you're screening out neurodiversity or people with severe neurodiversity differences?
We're screening out people that would qualify for having a psychiatric diagnosis.
Okay. Thank you.
And I don't know if that answers your question, but
yes, it does. I was just curious if there was differences based on neurodiversity.
Yeah, I mean, one of the things that I think is interesting is to look at kind of different sort of illnesses people might have had before they got COVID, and so we've looked at that. And certainly there are people that have had, a variety of different kinds of illnesses, and the people with the COVID controls do not have those illnesses. The
Because
people
if
with the
someone had
neuro-COVID might.
Because think about it, if we had the shutdown stuff there, so someone who suffered from normal minor depression and the lack of socialization and stuff, that could increase depression score, anxiety, or financial stress could affect things, even
Right.
with a minor sickness.
Right. I also want to remind you that we are asking people, and again, this is not necessarily an easy question for people to answer. Have you had any change in depression? So you might be a depressed person. You might think of yourself as generally kind of depressed or anxious, but we are asking, has it gotten worse? Not do you have it, but has it gotten worse? We also do the interviews, the Beck Depression Inventory and the Beck Anxiety Inventory to see if they do have it, if they do have depression and they do have anxiety. But what puts you in the group for neuro-COVID is whether you think you have gotten worse. And if you have gotten worse and you think it's because of COVID, you go in the neuro-COVID group. There are a lot of different ways to slice and dice this, but this is the way we've got it right now.
That's one. Thank you so much, Judy, for
Very
answering.
interesting work. Thank you.
I'm sorry, Abby. Yeah,
I said very interesting work. Thank you for your answers.
great.
Sure. Thank you for asking.
Yeah, thanks for your questions.
Yeah,
So
thank you.
one for your questions and your answers. This has been fascinating. Jay, did you have something you needed to add, you said?
Oh, no, just yeah, those were some really nice questions. Yeah. Thanks.
Excellent. Yeah, thank you so much, everyone, for joining. And Connie, I see that actually Abby asked a question you were thinking. So that was nice efficiency. Thank you. Well, it's great to have all of you join us. Thank you for being part of the community that cares about this as we try to help the humans longitudinally with this challenge that we're all dealing with COVID. We plan to be here for a while. We do these every quarter now. We used to do them every month when everybody was getting all these new awards. Now we do them quarterly. So if you know of other researchers funded by the US government in some way, or another government perhaps, we had somebody from Barcelona that presented a few months ago. Let us know. And as we build our next path. And Lauren, is there anything else you wanted to add?
No, you covered everything, Florence. I just want to echo the statements that we've all made already, which is thank you to all of our speakers. This has been a really fantastic set of presentations, and I think also a really good Q&A session too.
Okay, thank you very much, everybody. Be safe. Try not to get COVID, and hopefully we'll see you again soon.
Thank you, everyone.
And thank you, Lauren. Bye-bye.